Ladies and gentlemen, welcome to the Ophthalmology app of Medway. And they say that the journey of 1,000 miles begins with a single step. And this is the first step we are taking in our journey to study ophthalmology for the various PG entrance examinations, for the various FMG examinations that you want to take. And let's see what the harvest is. And this is the topic we will talk about: ophthalmology, the most beautiful structure of the human eye, isn't it? There is no doubt about that. Okay. And guiding you through this subject is yours truly, Shashwat Ray, who's going to talk to you through ophthalmology, which I believe firmly is the most beautiful structure. And I have this privilege, I have this honor of taking you through this journey. Okay. Remember, I am not here to teach you. I wouldn't dare to teach you. I wouldn't presume to teach you. But we may discuss, we may talk, and by this way learn medicine and ophthalmology, which is a wonderful, wonderful subject. Okay, so here it is, and with that, let's begin our journey of ophthalmology here. And there, we cannot do a better start than introducing you to one of my favorite quotes of medicine, which is given by no less than Sir William Osler, the father of modern medicine. Is it not? Father of medicine is Hippocrates, but father of modern medicine is Sir William Osler. And what he said is so true. And what does he say? He says this: "It's astonishing with how little reading a doctor may practice medicine, but it's not surprising how badly he may do it." Okay, isn't that right? So, ladies and gentlemen, kindly remember that it is true that with little reading you can pass your exams, but you won't become a doctor like that. And this is Sir William Osler, the father of modern medicine. Okay, so this is his quote, and I start invariably my apps, my lectures, my classes invariably start with a reference to Sir William Osler. So from one father to another father. And here we go to the father of ophthalmology, Albrecht von Graefe, father of ophthalmology. The mother we haven't been able to discover yet. Okay, and this is him. You have to identify them. History is important. Those who forget history are condemned to repeat it, is it not? Very well. So Albrecht von Graefe is supposed to be the father of ophthalmology, and after him there are many signs and instruments named after him. This is one of the most important. It's Graves' disease or thyroid ophthalmopathy. You have the lid lag, the famous lid lag. What is that? You ask the patient to look down, and as the patient looks down, you would expect the eyeball to move down and the lid follows it, not? So as you look down, the eyeball goes down, the lid follows it. But in this case, the eyeball follows, but the lid is not following, it's lagging behind. And that's called lid lag. You look at that here. So you look at the first picture where you have the lid retraction, the lid has gone back. And as the patient looks down, you see the normal eye, the lid follows. But in this case, there is a clear gap where you can see the sclera between the limbus and the eyelid margin. No, the lid is lagging behind. And that's the famous lid lag, which is called von Graefe sign in ophthalmology. Okay, so this is, we start with the father and the first named sign. But we'll discuss this as the time comes. So we begin our journey with one of the most important questions, embryology of the eye. We have to start with origins. And embryology of the eye, we have to remember some basic concepts. The three germ layers of ectoderm, endoderm, and mesoderm. The important thing is to remember in ophthalmology, we do not have any derivatives from the endoderm. Okay, so that's a big relief for us. We only have it from the ectoderm, which we divide into surface ectoderm and neuroectoderm. Then we have it from the mesoderm, and we third from the neural crest. But you'll be glad to know that there are no derivatives at all from the endoderm. Okay, so this is what is ectoderm. We divide into two types: surface ectoderm and neuroectoderm. That's the two derivatives, two parts of the ectoderm, beg your pardon, the mesoderm and the neural crest cells. So let's talk about that. And of the ectoderm, kindly remember, it is always that we've seen, for some reason, obscure reason, which I have not been able to understand, it is the surface ectoderm which gets the maximum number of questions, the lion's share of the questions. And so we pay particular attention to the surface ectoderm derivatives. We memorize this by a mnemonic called LEV, level. Level, we should all be at the equal level before we reach the exams. Level, is it okay? So that's a mnemonic to memorize it. I'm not very fond of mnemonics as such, but sometimes we require them. The lens, L starts for lens, so the crystalline lens of the eye, derived from the surface ectoderm. E for epithelium of all the intraocular structures except 2 What is that? The iris and the ciliary body. Except the iris and the ciliary body epithelium, they are not derived. The rest of the epithelium derived from the surface epithelium. And the vitreous, V for vitreous, but then vitreous comes from all the layers, which we will soon talk about. And the lacrimal apparatus. Remember what lacrimal means? Tears. So anything about the tears, lacrimal apparatus, the whole entire thing is derived from the surface ectoderm. So level it is. That's what memorize. Then what about the second part of the ectoderm, which is the neuroectoderm? And neuroectoderm memorized with mnemonic rows like that. And what is that? R for retina and retinal pigment epithelium. Naturally, remember, we talk about neuroectoderm, so it has to be the retina, retinal pigment epithelium. Then O for the optic nerve again, remember neuroectoderm. S for the muscles of the pupil, the sphincter and the dilator pupil, remember. So, a couple of muscles are also derived from this, the sphincter pupillae and dilator pupillae, which constrict and dilate the pupil respectively. And E for the epithelium, which was missing in surface ectoderm, that is the iris and the ciliary body epithelium. They are derived from the neuroectoderm. So, the row structures of neuroectoderm. This is R, O, S is sphincter and E for epithelium. Okay. And then we have the mesoderm, which is easily memorized by meso mnemonics. M for the muscles, that's obvious, extraocular muscles are all derived from the mesoderm. E for the endothelium of all the ocular structures and all the ocular and the orbital blood vessels. Remember, the endothelium of all the eye and the orbital structures are derived from the mesoderm. S for sclera and Schlemm's canal. Both the Schlemm's canal and the sclera are derived from the mesoderm. And V is again vitreous. Remember, O for ocular vitreous. O I kept just to complete the mnemonic. Okay, so meso. Remember, vitreous comes from everywhere. We did this in surface ectoderm. We're doing this mesoderm also. And then we have the neural crest cells, where the most of the derivatives of ophthalmology are from there, but you don't have to memorize the entire lot. Some of the most important are the corneal stroma and the endothelium cells of the cornea, the trabecular meshwork, remember, which is such a common site of blockage in glaucoma, the ciliary muscles, which cause accommodation, and melanocytes, which cause pigmentation of the iris. They all derived from the neural crest, amongst many others. We don't have to memorize all of them. Life is short and memory is precious. Okay, but of all the, remember, the derivatives, the most commonly asked are the derivatives of the surface ectoderm. Now, why it is so is beyond me, but it is there, so you better memorize it. Very well. Then the vitreous, as I said, comes from everywhere, all the structures, the surface ectoderm, the mesoectoderm, neural ectoderm, the mesoderm, and the neural crest. Very well. So that was about the embryology. So now we've got embryology out of the way. Origins you cannot neglect, and therefore we're going to talk the first of the systemic topics is about the orbit and the adnexa. That means the adnexal structures which surround the orbit. Okay, so let's talk about that, a little bit of anatomy, and then we go to the basic pathology. So let's talk about, but before we introduce the orbit, remember the orbit, it lies, the two orbits are the two bony cavities in the face, of the skull. And so therefore, to study the orbit, we have to study the skull a little bit of skull. And here, ladies and gentlemen, this is me that you see. It's my skull or your skull. It's all of us. Okay, it's all of us. We have this from ashes to ashes and from dust to dust. We will return. Okay, so these are the two orbits that we have. Okay, the two bony cavities, each of about 30 ml each. This is the bony cavity. If you see the orbit, it is just composed of 4 walls. There's nothing else. There's the superior wall, the inferior wall, the middle wall, and the lateral wall. So it's just a bony cavity of 4 walls. But what is the cavity? What is the shape of this cavity? And let's talk about that. The volume of the orbit, remember, the first MCQ is 30 ml. You have to have 30 ml and pyramidal in shape. So it's called pear-shaped or a pyramid shape. It's not. It's the pyramid, as we will soon see how. What are the other questions? The volume of each eyeball is only 6 ml. So in the 30 ml orbit, 6 ml eyeball fits nicely, occupying only about 30 to 40% of the orbital volume. And the eyeball is suspended from the orbit by 7 attachments. Let's talk about the clinical anatomy of the orbit. And remember, of the orbit, you see, we have the superior walls, the inferior, the medial walls and the lateral walls. And here, that's interesting anatomy. Look at that. The first question it says, what is the angle between the two lateral walls? So this is one lateral wall, this is another wall. Look at that. This is one angle, this is one lateral. Look at this, it's absolutely 90 degrees. My God, look at that. Look at the symmetry. The angle between the two lateral walls is 90 degrees. Look at that. Then what about the angle between the two medial walls? The two medial walls would be like this. And see, the angle between the two medial walls is they are parallel. The medial wall is absolutely parallel. And what about the angle between the medial wall and the lateral wall? If this is one medial wall, lateral wall, so look at that. It will be exactly 45 degrees. Look at that. Now, this is such an exact mathematics. The two lateral walls are 90. The medial and lateral is 45. And the angle of two medial walls is parallel. Okay, so you can see a lot of mathematics is astonishing that the eye obeys such precise degrees, is it not? So this is an important anatomical fact you memorized, and you can see this better in this beautiful diagram here, this sketch. Look at that. This is the pyramid that you can see that. See, this is one pyramid. You can see the base of the pyramid is where it opens in the face. This is another pyramid. So this is the apex, this is the base, and the two medial walls are parallel to each other. The lateral walls are at 90 degrees to each other, and the angle between the medial and lateral wall is 45 degrees. Not. So this is how it comes. So you see, these are the angles of the various angles of the orbit. You have to remember that. Very well. The next thing about the orbital anatomy is that, again, the two bony pyramids. Look at that pyramid shaped. This is the base of the pyramid opening on the face, and the apex is behind. So, pyramid is 4 walls. You have a superior wall, inferior wall, medial wall, and lateral wall. And you can see how thick they are. All except the medial wall. The medial wall, remember, happens to be the thinnest wall of the orbit, as you can see it here. Superior, inferior, and lateral are so thick. Why it is so thin, as you can see here? Because of a wall here. It is so thin here because you see, this typically is because of a very, very thin wall, which is called as the lamina papyracea, is it not? It's called lamina papyracea because it is like a paper dosa. Lamina papyracea, and this is the thinnest wall of the entire orbit, which breaks very easily. And lamina papyracea, if you've done your anatomy well, you might remember, is that lamina papyracea is a wall of the ethmoid sign, is it not? So this is the thinnest wall, but apart from that, the rest of them are very, very thick. And here you have to remember the rule of 7. Okay, remember the rule of 7, which is a very nice rule. There are 7 bones, 7 muscles, and 7 nerves. Remember, the bones we don't have to memorize, but the 7 muscles we do, and the 7 nerves also we do. So let's look at the 7 muscles which suspend of the extraocular muscles. They are called extraocular because remember, these muscles lie outside the eyeball. Okay, there are some muscles which are inside the eyeball also. We call them intraocular muscles. But there are some muscles which are outside the eyeball. There are 7 of them. We call them extraocular muscles. What are they? Let's look at that. Superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique, and the levator palpi superioris, the LPS. Is it not? The 7 muscles, we call them extraocular because they lie outside the eyeball. And then, so extraocular muscles, remember, they all arise from a common origin, which is at the back of the eyeball, is it not? Back of the orbit. So this is the eye, and look at that. This is the common origin here that you see here, and this common origin is called the annulus of Zinn. Okay, it's called. You remember the word annulus means a ring, is it not? The word annulus means a ring, as you can see the ring here. So this is, you have to memorize the annulus of Zinn. All the 6 muscles arise from there except one, the inferior oblique, and you can see that this is the inferior oblique. You can see this is the inferior oblique. The rest of them, superior rectus, superior oblique, medial rectus, lateral rectus, and inferior rectus, all of them arise from the annulus of Zinn. So that's a very important MCQ, which is the only muscle which does not arise from the common origin. It is inferior oblique, is it not? That's important question. And so they arise from there. But if they arise from there, they have to insert somewhere. And where do they insert? They insert on the limbus. The limbus is the area between the cornea and the sclera. This is limbus. And all attached to the area of the limbus, but there is a here discrepancy. Look at that. What is that? The extraocular muscles in the limbus, but they are not at the same distance from the limbus. Some muscles are attached closer to the limbus, some are away from the limbus. And here is an important MCQ. Remember, the medial rectus muscle attaches closest to the limbus. That's an MCQ. You have to remember. And how to memorize the insertions is the MILS, another mnemonic, MILS. Remember MILS? Okay, what is that? M for medial rectus, I for inferior rectus, L for lateral rectus, S for superior rectus. So the closest attachment to the limbus is the medial rectus, followed by the inferior rectus, then the lateral rectus and superior rectus. Okay, and so you can see that here. Look at that. So this is the superior rectus, inferior rectus. The closest attachment is the medial rectus, followed by inferior rectus, followed by lateral rectus, and the furthest away from the limbus is the superior rectus. This is the way to memorize. And if you join this line, okay, if you join the insertions with a line, with an imaginary line, then that line is called the spiral of Taylor. Please remember, this is just an imaginary line. Okay, if you take a pencil and join the insertions of at the limbus, look at that. So superior, inferior, medial, lateral. We take this imaginary line. This is a spiral, as you can see, and this name of the spiral is a spiral of Taylor. Okay, so that's important to memorize. So they attach and they insert the limbus, and the medial rectus is the closest. Two MCQs immediately. Inferior oblique is the only muscle which does not arise from the common origin. Medial rectus is the closest attachment to the limbus. And then remember this lovely formula called LR6SO4R3. I don't have to tell you what this means. It stands for the nerve supply of the muscles. Remember, lateral leg is supplied by the 6th cranial nerve, superior oblique by the 4th cranial nerve, and the rest of them, R3, rest of the muscles are supplied by the 3rd. So LR6, lateral rectus supplied by the abducens, the superior oblique supplied by the trochlear, and the rest of the muscles, all of them, that means superior rectus, inferior rectus, medial rectus, and inferior oblique, as well as LPS, are supplied by the oculomotor nerve. LR6, SO4R3. Easy formula to memorize that. And here now, another important, which I've already mentioned, the thinnest wall, remember, of the orbit is the medial wall, which you've already seen. And that's important for us clinically because it's so thin, so the infection can come in from the ethmoid sinuses, enter into the orbit. So that's called orbital cellulitis. We'll discuss in a second. So that is how any infection of the ethmoid sinus can pass from the ethmoid sinus through the lamina papyracea into the orbital cavity and cause orbital cellulitis. Okay, so the thinnest wall, an extension of the infection from the ethmoid sinuses, can take place like this. Okay, so this is what we need to remember. Very well. Then now we go to the next. So having the basics of anatomy here, let's go to next, which is the important topic called blowout fracture. It's called the blowout fracture. And what is that? It seems to blow out. Blowout fracture is defined as a fracture of the orbit which does not include the rim. Okay, that the fracture of the orbital walls, but not involving the orbital rim. This rim is very, very powerful and it's difficult to break it. So orbital blowouts do not include the rim as a definition, inclusive in the definition of a fracture, and this is the most common fracture of the orbit. Okay, this is the most common orbital fracture. Very easy to get it on a slippery floor, on a slippery bathroom floor, while driving, while you have an accident. So it's very easy to get it. And here an important name. So you remember the size of the blunt object or size of the trauma that hits the orbit has to be bigger than the size of the orbital aperture. Okay, so remember that you can have a blowout fracture if you hit with a cricket ball or even a football, but you cannot have a blowout fracture if you get hit by a golf ball, because the golf ball is the same size of the orbit. It has to be bigger than the size of the orbit, is it not? So that's an important qualification for causing a orbital fracture, blowout fracture. And the very important MCQ, the most common wall to fracture is, surprise, surprise, it's not the medial wall, which you would expect because the thinnest wall, but it is actually the inferior wall. It's actually the inferior wall. Okay, this is the most common, very important MCQ. The inferior wall is the most common fracture in a blowout fracture. But why should that be? And that's an interesting anatomical question. If you look at this, so we'll go back to the diagram, so it makes for easier studying. Look at that. You see, I told you the medial wall is the thinnest here. So why doesn't it fracture? Why does the thicker orbital, the inferior wall fracture more? The reason is, you see, because of anatomy. Remember, the thinnest wall is the lamina papyracea, but it does not fracture because it is supported by the ethmoidal sinuses. Remember, the ethmoidal sinus is full of air cells, is it not? The ethmoid sinus, you know, is full of air cells. It is like a honeycomb structure. And any structure that has air cells or honeycombed gives a lot of strength to the overlying wall. And that is why, despite being hit and despite being the thinnest wall, the medial wall does not fracture. But the inferior wall, despite being thicker, sits on top of the maxillary sinus. And the maxillary sinus, remember, is not full of air cells. It's a hollow structure. It's a cavernous structure. So the maxillary sinus, being hollow, cannot support the inferior wall and it fractures more. However, the ethmoid sinus, made or composed of air cells, supports the medial wall much better. And that is why the structure to fracture most in a blowout fracture is always the inferior wall and not the medial wall. Can you remember? This is an important question, so we have to remember that. So this is what we have to remember. So can you remember that our support structures for all of us, despite however strong you might be, ladies and gentlemen, please remember your support structures have to be equally strong, is it not? Very well. So we were talking about blowout fractures and that's it. Then remember how to diagnose the classic triad, how the patient presents to us is diplopia, infraorbital anesthesia and enophthalmos. Okay, remember this is memorized by the mnemonic called DIE, D-I-E, not that death, not that death. We all die, of course, but not today, not God willing, not today. And so D for diplopia of double vision, infraorbital anesthesia. This area will become anesthetic because you damage the infraorbital nerve here. So patient cannot feel any sensation, pain or anything. And enophthalmos, the sunken eyeball, the eyeball goes inward, okay? Enophthalmos. So classically, the three things which they present to us, the DIE. And one more thing which you have to remember is that sometimes blowout fracture, particularly in children, it may activate the oculocardiac reflex, OCR, which is what it is when you press the eyeball or you pull on the muscle. Anything that presses or causes stimulation of the muscles may cause bradycardia. It must cause a reflex, which is the classic triad of nausea, bradycardia. In fact, this bradycardia is very dangerous. It may fall down to as low as 20 to 30 heartbeats a minute, and syncope, the patient would faint, is it not? So the classic triad, remember OCR or the ocular reflex, is bradycardia, nausea and syncope. So this is the typical, this is extremely important question, particularly in pediatric ophthalmology, where it's an indication for emergency surgery. Okay, that's you have to remember. And this is how the patient presents to us. See, the patient looking up, this eyeball goes up, but this eyeball is not able to move up. Why is that? Because the inferior rectus muscle is trapped by the fracture line. Okay, so when you want to look up, the superior rectus has to contract and the inferior rectus has to relax to allow the eye to move up. So here the superior rectus is contracting all it can, but the inferior rectus is not able to relax because it is incarcerated or trapped in the fracture line. So neither is able to contract nor relaxes. So try as you might, the patient is not able to look up, and that is why he has double vision, because one eye looks straight, is looking upwards, the other eye is looking straight forward. That's why it's double vision. This is how they present to us, okay, in the OPD after trauma. And the famous teardrop sign, I always ask them to look at that. We call it teardrop sign because the orbital contents seem to herniate into the maxillary sinus like a teardrops, okay, like a teardrop like this. You can see the inferior wall here intact, but the inferior wall is fractured, orbital contents herniate down. And here you can see the ethmoid air cells, which you see, which is supporting the medial wall, but you can also see the hollow maxillary sinus, which is not able to support the inferior wall as effectively as the ethmoid sinus does the medial wall. Okay, so teardrop sign. And how do we manage it? Remember, management principles, you have to just remember two things. One, what are the indications for surgical repair? So repair is not always done automatically. First, if there's a fracture of at least 50% of the orbital floor, 50% of the orbital floor, then we try to repair it. Second is if there is enophthalmos more than 2 millimeters. So if the eyeball sinks inwards, if it's more than 2 millimeters inwards, this may cause double vision and problems. We have to again try to repair the fracture. And of course, if you have double vision with limitation of up gaze or down gaze, then again it's an indication for surgery because the patient obviously cannot tolerate diplopia, right? So these are the three indications of surgery for blue rod fracture. Otherwise, most cases, we would just leave it like that. Okay, and there's one need for urgent repair. Urgently, which is required when the pediatric blue rod fracture is often resulting with entrapment of the extraocular muscles. It may cause the oculocardiac reflex, and again, it is an emergency because the bradycardia may be so severe as to jeopardize the life of the patient. So we have to do it in a hurry because the bradycardia syncope and the nausea can be life-threatening. Okay, so this is an indication for urgent repair of a blue rod fracture. Very important question, particularly for people who are attempting the INI-CET exam. So we've done our orbital fracture. We go to next topic, which is orbital cellulitis. Okay, let's talk about that. The orbital cellulitis, ladies and gentlemen, and as you can make out, is infection of the orbit. Remember, it is the first MCQ, it is the most common infection of the orbit. That's number one question. Okay, but what exactly it is? It's an acute infection of the orbit, but remember, it's behind the orbital septum. The orbital septum is a structure which separates the orbit from the eyelid. Okay, so remember, anything that is behind the orbital septum will cause orbital cellulitis. If the infection is in front of the orbital septum, it will cause preseptal cellulitis. Okay, so behind the orbital septum, and there's no involvement of the eyeball per se, but the soft tissue behind the eyeball. So actually, orbital cellulitis does not involve the eye to begin with, but only the soft tissue within the orbit. And remember, by definition, it has to be behind the orbital septum. Okay. And remember, orbital septum is much more common in children. Okay, it's much more common in children than adults. And in children, it happens to be the most common cause in children is ethmoidal sinusitis. Kindly remember, orbital cellulitis, overall, the most common cause MCQ is ethmoid sinusitis. So you have an infection of the ethmoid sinus, it penetrates through the medial wall and enters into the orbit, causing orbital cellulitis. And the next question is, what is the most common organism? And this happens to an old friend of ours. Well, not very friendly, let me tell you. Staph aureus. In ophthalmology, you will meet him everywhere. Okay, Staph aureus. And these are nowadays MRSA, methicillin resistant Staph aureus, as you know, makes our life even more difficult to treat it. And streptococci. But if given both choice, it will be Staph aureus. Okay, most common infection of orbital cellulitis. What else? How do you diagnose this? Remember, first thing that you will see the child's eye or the eye is proptosis, exophthalmos coming out, eyeballs coming out, proptosis. Kindly remember, it is the most common cause of unilateral proptosis in children. Kindly remember, it's the most common cause of unilateral proptosis in children, not in adults though, and unilateral because orbital cellulitis rarely is bilateral. If you get bilateral proptosis, then the answer is different. Unilateral proptosis in children, the commonest cause is orbital cellulitis. And apart from what else do you have? You may have chemosis, which is conjunctival edema. Okay, conjunctival edema, restriction of the ocular movement, so the eyeball will not move. So, and there will be loss of vision and diplopia. And look at that, you have this very famous congestion. You can see that, you can see the redness, which is extending beyond the margin of the orbit. So, you have well demarcated. You can see well demarcated means you can clearly make out. If you take a pencil, you can draw. So, well demarcated lid edema extending beyond the eyelid margin. That is a very typical sign. So, erythema, which is redness and inflammation, the loss of vision. Pain with ocular movement is an extremely important sign, which sometimes helps us in diagnosis. But when the eyeball moves with muscles, it's painful. So, this is another important sign of orbital cellulitis. Investigation, we can do an MRI or contrast enhanced CT. So, sometimes we like to ask this MRI or CT and contrast enhanced CT we can do and pick up the infection. Management is an uncomplicated case. That means it's simple orbital cellulitis. Uncomplicated means it is not involving the cavernous sinus, let us say. So, uncomplicated cases with antibiotics alone is enough. For what do we use? Vancomycin intravenous with a third generation cephalosporin like ceftriaxone. Remember why vancomycin? Because remember they are MRSA. So, this combination of antibiotics, it treats uncomplicated orbital cellulitis, but sometimes you have to do surgical drainage also. Particularly, when you have to drain, it becomes an orbital abscess. The orbital cellulitis may go into orbital abscess, then you may have to drain it, and you have to drain the involved sinus, which is most commonly, as you know, the ethmoid sinus. So, this is about orbital cellulitis. Can you remember the questions? Often seen in children, commonest cause of unilateral proptosis in children, The most common being ethmoid sinusitis, the most common organism being Staph aureus, and treated by a combination of vancomycin and ceftriaxone. Very well. Now, sometimes what happens is a disastrous condition occurs. This orbital cellulitis, it goes into the cavernous sinus. You know that the orbits here and just behind is the brain. So, let's look at CST, a disastrous condition, cavernous sinus thrombosis, where what are the cavernous sinuses? A pair of dural venous sinuses on either side of the sella turcica. Okay? So, sella turcica, which is nothing but a Turkish saddle, and divided by the septa. That's why it's called cavernous, because what are these caves? They're divided by the septa, so we call them caves. That is why they're called cavernous sinuses. Remember the anatomical jewel box. The cavernous sinus is often called the anatomical jewel box because of the intricacy of its structures. And it is, as you can see, look at that. This is the two cavernous sinuses with so many important structures here. The third nerve, the fourth nerve, the two branches of the fifth nerve, and the sixth nerve with the internal carotid artery right in the center running through this pituitary gland here. The two sinuses on either side of the sella turcica. And so, obviously, it occurred by usually a bacterial emboli when the infection occurs, and there's a bacterial emboli and it converts into thrombus. So, it converts into thrombus, and that's why it's called CST, cavernous sinus thrombosis. Okay. And the most common MCQ, remember, is headaches. Severe headaches are seen in orbital cellulitis. I beg your pardon, cavernous sinus thrombosis. Severe headaches are one you have to remember, but more in favor of cavernous sinus as compared to orbital cellulitis is the swinging fever, rising up and down with chills and rigors, and CNS signs also, because remember it's in the brain, middle cranial fossa, periorbital edema you'll have chemosis again, conjunctival edema, and painful ophthalmoplegia, which means ocular movements are restricted and it's painful when you try to move the eye. So, multiple signs and symptoms of cavernous sinus. Remember, it's a life-threatening infection, very serious life-threatening infection, which can be diagnosed by proptosis and extraocular muscle paralysis as well. So, very similar to orbital cellulitis, just more severe with lot more systemic symptoms. Okay. Remember, the earliest sign is usually MCQ, sixth nerve paralysis. Now, why is that? If you look at the anatomy here, that makes it obvious. Okay. You see the third nerve, the fourth nerve, the two branches of the fifth nerve, and the sixth nerve. So, why should the sixth nerve get affected first? MCQ, remember. That's why you see, because see these nerves, third, fourth, and the fifth, are embedded in the wall of the sinus. So, they are protected by a barrier of the wall of the sinus. But the sixth nerve is right in the center. It's vulnerable and open. So, that is why the sixth nerve is the first nerve to be attacked in cavernous sinus thrombosis, simply because of its location. Again, anatomy, remember, anatomy is destiny, as Sigmund Freud said it. So, this is your symptoms. We have this, and proptosis, early sixth nerve palsy, and again, the same thing I showed you, this one. And usually because they are, remember, the two cavernous sinuses, they are connected by intercavernous sinus. And like all veins in the CNS, there are no valves there. So, very easily, infection goes from one to the other, and within 48 hours, sometimes it becomes bilateral. So, cavernous sinus thrombosis mostly seen bilateral, if you allow it to progress that much, because it moves from one sinus to the other, because there are no valves there. So, this is often bilateral. Within 48 hours, you see the symptoms of disorientation, drowsiness, and coma. So, that's how distinguished from orbital cellulitis, because they'll have drowsiness, coma, and disorientation. This is in cavernous sinus thrombosis. And one important sign which we call is the Parkinson's sign. Please remember, Parkinson's sign, not Parkinson's disease. Parkinson's sign is the involvement of the sixth nerve with Horner syndrome. Now, why is that? Because remember, Horner syndrome is oculosympathetic paralysis. So, what happens if you look at again, see, this is the internal carotid artery, and the internal carotid artery winding around the internal carotid artery like an anaconda or a South American snake is the famous sympathetic plexus. Okay. And see, so you have the sympathetic plexus is damaged, OSP, oculosympathetic paralysis, it causes Horner syndrome. And look at that, you have the internal carotid artery. So, when the sympathetics around the internal artery gets damaged, plus the sixth nerve is very close, as you can see here. So, involvement of both the sixth nerve and the Horner syndrome due to involvement of the sympathetic plexus is called as Parkinson's sign, and this Parkinson sign, whenever a patient presents to us like this, it gives us a clue that the lesion must be lie in the cavernous sign. So this is a very important localizing sign. It tells us that the pathology is in the cavernous sinus, is it not? So that is a very important clue here, and they're treated with intravenous antibiotics, naturally, with IV heparin because thrombosis, and systemic steroids to reduce the inflammatory signs. But remember, this life-threatening. In 30% of the cases, the patients die out.